Good morning, everyone, and happy Saturday. How's everyone doing out there this morning?
Good morning. Happy
Morning.
Saturday.
Good
Happy
to see
Saturday.
everybody.
Good morning. Well, we were just chatting in the preamble here. It seems like forever that we haven't been together, but we did take last Saturday off due to the 4th of July, the 250th anniversary of the signing of the Declaration of Independence, and so we took that off. But it seems like it's been months that we've been apart, it seems, and we're all excited to be back here together. For those that are new, this is Voices of Healthpointe, which is, as the name implies, it's just all of us that are, going to visit here from 8 a.m. to 9 a.m. Eastern Standard Time and talk about things related to Healthpointe, which is a program that people that are in here might even be coaches on that program. Maybe there's clients, maybe there's prospective clients. And for those that don't join us live, this does get uploaded onto the YouTube channel called Voices of Healthpointe. So, and the way we often do things is we have, what we call docket items, or this morning, docket item. We've just got one docket item, and that is mine. And then we just kind of get into the fun part after going through any docket items. And the fun part is just where we all kind of chat either on that docket item or on other topics, and that's where it gets really, really fun, is that discussion. But my docket item is titled "The Number Your Annual Blood Test May Be Missing." And I threw out kind of like a pop quiz beforehand in the preamble. Anybody guess what that number might be? Well, there was no guesses, and but we'll do the reveal here. So let me get into that. Before I do, I'm going to do a mute all, only because it keeps any distractions from happening while I'm going through the docket item. So just know that you just have to unmute yourself before making any comments as we wrap up here. So first, I want to say that the content shared here is for informational and educational purposes only. It is not intended as medical advice, diagnosis, or treatment. Always consult your healthcare provider before making any changes in your health routine. Our discussions draw on wellness concepts similar to those found in the Healthpointe methodology, which we hold in high regard. The ideas presented are independently developed and do not represent or speak on behalf of the Healthpointe brand. And again, this is titled "The Number Your Annual Blood Test May Be Missing." In fact, likely is missing, as you'll see. What if one of the most important numbers for understanding your future metabolic health wasn't included in your last annual blood test? Each year, millions of Americans receive routine laboratory work. They review their cholesterol numbers, fasting glucose, A1C, blood pressure, and other familiar measurements. Those numbers matter. They provide valuable information about our health today. But what if one of the earliest changes in metabolism begins years before many of those numbers ever become abnormal? I recently listened to an interview with Dr. Mariella Glant, a board-certified endocrinologist and obesity medicine specialist. Dr. Glant graduated from Harvard Medical School, completed her residency at Beth Israel Deaconess Medical Center in Boston, followed by an endocrinology fellowship at New York Presbyterian Weill Cornell. After more than 2 decades treating patients with diabetes and metabolic disease, she has become a respected voice in metabolic health. One of the central messages from her interview was surprisingly simple. If we want to understand metabolic disease earlier, such as type 2 diabetes, we would do well to look at the sequence in which it develops, not simply the measurement that appears later. Let's begin with insulin. Most people know insulin has something to do with blood sugar, but fewer understand its broader role. Insulin is a hormone that helps move glucose into cells and signals the body to store excess energy, first as glycogen and then as fat. Every time we eat carbohydrates, they are broken down into glucose and absorbed into the bloodstream. The pancreas responds by releasing insulin. Insulin escorts that glucose into muscle, liver, and other tissues where it can be used for energy or stored for later use. That is exactly how the system was designed to work. Problems don't exist. Problems don't usually begin, rather, because insulin exists. They begin when the body is repeatedly asked to produce large amounts of it. While several factors contribute to insulin resistance, one of the primary dietary drivers is the repeated demand for insulin created by a long-term pattern of consuming refined and processed carbohydrates. Think about this in the context of what can happen over years, not days. Repeated glucose spikes create repeated demand for insulin. Repeated demand for insulin leads to chronically elevated insulin. Over time, something remarkably begins to happen. Let's think of it this way. Imagine living next to railroad tracks. The first few nights, every passing train wakes you up. Every whistle gets your attention. But after months or years, something changes. The trains have not become quieter. You've simply become less sensitive to them. The signal hasn't changed. Your response has. Our cells can behave in a remarkably similar way. When exposed to elevated insulin over long periods, they gradually become less responsive to insulin's signal. They become desensitized. The pancreas responds by producing even more insulin to achieve the same result. Now something fascinating occurs. The body often compensates so successfully that the blood glucose remains normal. A1C remains normal. From the outside, everything appears perfectly healthy. Perhaps you know someone like this. Maybe they carry quite a bit of excess weight. They eat a diet high in refined carbohydrates and sugars, yet every year they proudly say, my glucose is normal. My A1C is normal. My doctor says everything looks fine. That may be true, but it may also be that their pancreas is busy producing much more insulin than it used to, simply to keep those numbers looking normal. Eventually, however, compensation has its limits. The pancreas can no longer keep up with the increasing demand. Only then do fasting glucose and A1C begin to rise. This is why many clinicians who specialize in metabolic health view fasting insulin as a leading indicator. It often begins changing much earlier in the story. Interestingly, fasting insulin is frequently not included in routine annual blood work. Current national screening guidelines emphasize glucose-based readings because these measurements have long-established diagnostic standards, and fasting insulin is measured accurately by laboratories, but there's less consensus regarding how it should be used as a routine screening tool. As a result, many clinicians with a particular interest in metabolic health choose to use it more extensively than current national recommendations. If you happen to have a fasting insulin measurement, it's helpful to understand how many metabolic health clinicians interpret it, because many standard laboratories report a reference range extending to approximately 20 to 25 MIUs per milliliter, meaning values within that range from 1 to 25 may simply be labeled normal. It's an important reminder, though, that normal and optimal are not always the same thing. We've discussed that before here on this program for sure. So many metabolic health clinicians, that is specialists, they view the numbers differently. To them, above 12 MIUs per milliliter frequently reflects significant insulin resistance. Between 8 and 12 tends to suggest developing insulin resistance. Between 5 and 8 is often considered good, and below about 5 is generally considered excellent. One of the most interesting part of Dr. Glant's interview wasn't actually about insulin. It was about education. Early in her career, she spent a considerable time drawing beta cells, explaining receptors, and teaching endocrine physiology before asking patients to change how they ate. Over time, she discovered something, though. The people who experienced the greatest success didn't need a graduate level lesson in endocrinology. They needed a simple plan. They simply needed to know what to eat. The biology began changing long before they fully understood the biology. That observation resonated because it so closely mirrors what we practice here within Healthpointe. When someone begins our program, we don't first teach insulin receptors, pancreatic physiology, or metabolic pathways. We simply begin. We talk about what did you eat during the 3 protein-only jumpstart days, about during the menu plan phase of days 4 through 28. What did you eat during the add more food phase of weeks 5 and 6? Those simple daily actions begin changing the very biology we've been discussing. Understanding the science, though, can be helpful. In fact, it's one of the reasons we spend these Saturday mornings together. Understanding the biology removes shame. It replaces confusion with understanding. It reminds us that our bodies are responding logically to the environment we repeatedly create. But understanding doesn't have to come first. Action does. The science simply helps explain why those actions work. So the next time you review your annual blood work, take a moment to see whether fasting insulin is included. If it isn't, consider asking your healthcare provider about it. It may provide valuable insight into your metabolic health long before glucose or A1C begin to change. All right, guys, so there you have it. Mystery solved. The answer to the number your annual blood test may be missing: fasting insulin. Now you know. And again, people are muted. I did a mute all. Feel free to chime in on any comments on that. And if not, we'll, yes,
Eric,
good morning.
Yeah, I have a question. So you're saying that when you have your blood test done, it should be a fasting blood test? Because my doctor says you don't have to fast before your blood test.
Uh, that's interesting. Most blood tests, and of course, for getting like a standard panel, will do it in a fasting state. If it's drawing things related to blood sugar. So yeah, with blood sugar, in fact, kind of I don't want to say the joke within physicians, but kind of the common understanding is their frustration that even though the patient is asked to do a fasting state, so like if they have a 10 a.m. appointment, they should, I'm trying to think of the hour window. It's I think 10 to 14 hours of fasting. So you wouldn't want to eat, say, around 12 hours. We wouldn't want to eat after 10 p.m. So you just fast through the night. You don't eat anything through the night, and then you go in. But the point is you don't have a breakfast before going into the physicians to get that blood draw. You get that blood draw in that fasted state because they're measuring, in a glucose and also if it includes the insulin number as well, they're seeing, did those numbers come down in that fasting state. If you eat just before going in, then your body is responding to that food and elevating we know your blood sugar rises after you eat. So that's going to give we'll say, I guess, broadly speaking, maybe a false reading. So Hank, I don't know why they would suggest to eat unless it's just some different type of test that's not pulling in blood sugar. Is the resulting panel that they're giving you, including numbers like blood sugar, A1C, and so forth?
It shows those, yes, but I don't know why, and it kind of threw me the first time he ever said that. This is a non-fasting, just you can have something before. Usually going about 9:30 for the blood draw, and I usually have a wellness bar. That's what I do because I enjoy it with a cup of coffee. But maybe I should try one. Just even though he says non-fasting, I'll do a fasting and see what kind of results it shows. Because I got one coming up very soon.
Yeah. Yeah, that would seem to be a good thing to do. And then you can look back on past lab results and see and kind of compare and contrast. And then, certainly just ask them, just say, as I understand it, if you're looking, in this lab report. So for example, to be clear, it's not going to affect like cholesterol numbers, your LDL, your HDL, your triglycerides, and so forth. Those, the needle on those it's not going to move the needle in, whether you ate or not before you went in and got that blood draw. But glucose, I mean, think of it in this context, or maybe explain it to your understanding of things to your physician in this context. We know the popularity of CGMs. We've talked about it on this program. Many people get CGMs. In fact, Emily, many of you know Emily, my wife, just ordered another CGM because she just wanted to slap one of those on the back of her arm. And maybe you guys see that with people. It's about a quarter size device that just sticks on the back of your arm. And that is a CGM, a continuous glucose monitor. And the point that I'm making, Hank, is you can literally eat something. Let's say particularly if you eat something carbohydrate or sugary, let's say you have a bagel and a donut. Wonderful
Never
sounding,
touch
right?
those.
Yeah. Woo. And but you can literally over the ensuing, relatively short amount of time, certainly within the hour, typically, you're going to see on your app, on your CGM app on your phone, you're going to see your blood sugar line start to rise and rise and rise. And that's one of the things. I don't know how many people in this in the audience here have ever worn a CGM, but it's one of the fascinations that people get with a CGM. It's so insightful in terms of the stimulus and response, where you eat. Again, if you eat particularly poorly, if you eat some potato chips or some sugary donuts, and it's not a mystery. That's what happens. You see on your phone app, on your CGM app, you see your blood sugar start to rise. So the point then, Hank, is if you did that, I know you wouldn't do this, but you say you had that sugary donut, but even a meal bar or something like that will have some effect as well. But if that blood sugar rises like that, and then you walk into that office and they stick a needle in your arm and they pull blood, they're pulling that same blood that is giving that measurement of the elevated glucose as a response to the food that you just ate. So the printout that they produce, the lab report that they produce, would show a more elevated glucose than what would normally show in a fasted state without the food in you. Yeah. So it's a long way, I guess the way I would say for anyone, if a physician, now again, I don't understand all the context here. Obviously, as we say in the beginning, follow what your physician is saying. But if you want to be kind of empowered or kind of advocate or ask some questions, just say, hey, doc, I understand, people wear CGMs, continuous glucose monitors. If I ate before I came in and got this blood draw, my CGM, if I wore one, would show my blood sugar elevating, rising. So shouldn't I, be not eating before I get this blood draw? Because otherwise you're getting a blood draw that shows an elevated. And I don't know what they would say. I can't imagine them saying anything other than, yeah, that's true. Yeah, you should come in fasted. I can't imagine them saying anything other than that.
Hey,
Well,
Eric.
I think I appreciate that, but I think what I'll do this time, I'm my own doctor most of the time anyway.
Right.
I
Yeah.
say I'm gonna try it before doing fasting, just to try it and compare results from the last 6 months. And I think it'll be well worth a try. But I appreciate
Oh,
your input.
absolutely. Yeah. Absolutely.
Thank you.
You bet. Yeah, in fact, I can imagine the numbers perhaps being notably different, and your doctor might be saying, "Hey, these numbers look good. They look lower," and then maybe you can tell them. Sorry, was that
question.
Pam? Yeah.
It is. Just checking then, how long do the metabolic physicians, how long do they suggest? Because I oftentimes will ask that question myself. How long should one go without eating? I mean, you could go to bed at 10 and not eat, but is it better to go even longer? Or what do they recommend as far as a real fasting blood test?
Yeah, that's a great question, Pam, and I would have to review that myself to hit you with a hard number. But I do know that, if you're in that range of that 12 to 14 hours, as I recall, that is kind of like the ideal. I remember learning once where for these other types of tests, not just simple blood sugar, where they were making it clear, because these days, some people are capable of fasting long time, right? People, maybe some of us here have done long fasts. They know they can fast for 24 hours or, you know, 1 day, 2 days of fasting. And that's not what you want to be doing you don't want to be going that extended on your fast. So I can look real quick here as we move through the program. I might be able to get that hard answer to you, but I believe it's in that roughly that 12-hour fasted state is, going to get you with an accurate, measurement in here.
Okay.
Yes.
This is Lon. I'm the guy that has the testimony about A1C. I've had my doctor do both fasting for 12 hours. That's what she usually recommends. They always ask me that when I do a fasting test. But this last time she said I don't have to fast. So there must be some reason why you do it one time versus the other time. But I fasted both ways, fasted and unfasted, 12-hour fast.
Do you recall, Lon, was there a significant difference between your two glucose numbers, the glucose number on your fasting test and your glucose number on your non-fasting test?
No, I don't recall because it's ever since I've been on the Healthpointe program, it's gone from 7.9 down to 6.5, and my latest one just last week was 6.4. So the trend is downward, and so.
Oh, okay. So that is referring to your A1C number, right?
That's correct.
Okay. And that's right. I remember your phenomenal testimony on the A1C improvement. Okay. So just so that there's not any confusion here, A1C is measuring I'll try to say this in a way that is accurate, but it's not super specific. A1C is measuring kind of your glucose levels over the life of your red blood cell, which is about 90 days, about 3 months, 90 to 120 days is what that is. It's basically looking and saying, okay, glucose, as we just talked about with Hank, glucose is you eat something and your blood sugar rises, and then falls, as insulin in your body brings it down. So it's very, very reactive, very almost, I don't want to say minute to minute, but certainly hour to hour, day to day. Glucose rises and falls throughout the day. So it's very reactionary in that regard. A1C is not a day to day. A1C says over the life of a red blood cell, it's measuring what's called the glycation, kind of the sugar that attaches to the hemoglobin part of the red blood cell. And it's so if you have high levels of blood sugar over time, over 3 months, you're going to measure a higher A1C. If you have lower, healthier levels of glucose over the life of that blood cell, you're going to have lower and in range A1C. So for an A1C number, whether you fasted before you got that blood draw or didn't fast before you got that blood draw, it wouldn't move the needle, because that's only 1 day out of 90 or 100 days of the red blood cell. Okay, so I hope that's not too confusing, but glucose is very short term. Glucose, if you're wearing a CGM, you can eat a donut and see your blood sugar go up and then come down. But A1C is over the course of the entire life cycle of the red blood cell. So getting back, and thanks again for that, Lon. And again, the A1C number is, that ultimately is what you're looking for, is a healthy A1C number, because any of us, all of us in this group, let's just say that we've been perfect Healthpointe practitioners for the last, week, just been eating super, super clean. Any of us eat a bunch of donuts right now, our glucose is going to go through the roof, okay? But our A1C number, if we only did it today, our A1C number is going to stay pretty much the same if we only did 1 day of donut eating, okay? Here's one of a couple of comments. Well, first of all, any other comments that anybody has? This has been really great. It gets into a little bit technical, but what I'm hearing, because those that go in and get their tests and exams and stuff like that, they hear this, right? They hear about A1C. They, like Lon was talking about, they hear about what Hank is talking about, whether to come in fasted or non-fasted, and it kind of informs the understanding.
Eric, so am I understanding then that when you wear a CGM, that's very instant, it's how your body reacts. But the A1C is kind of where your body's at overall. Is an A1C number a more important number in your blood work then? Because it's more stable?
Yeah, that's a way of thinking about it. That would be a good way to think about it, sure.
Because it's more habitual, is how your day-to-day activity is, not versus I had a chocolate chip cookie.
That's correct. That's correct. Yep, that's a real good way. A nice, and I like it how you simplify things, Carol. It's just a nice simplified way to understand it, that A1C is showing your levels of blood sugar over time.
Mm-hmm.
Yeah. Mm-hmm.
Okay. Yeah. Okay. I just want to make sure I understood that properly. Thank you.
Yeah. I want to reinforce that. Your day. I prick with the old-fashioned way with my finger, and during the day, I monitor 2 hours after I eat. I test for my sugar, and depending on what I eat, it'll fluctuate. But the A1C, as Eric, so you did a great job explaining this of A1. It's a much more accurate call for what your glucose level is over time.
Mm-hmm. I'm trying to think of a good metaphor, and I think we all kind of understand it, but I'm going to take a stab at it here. Let's say we're driving a car over the course of 3 months. Okay, we get in a car, we're going to drive it for 3 months, 90 days. That represents of course, the life of a red blood cell. When we're driving that car, there's times where we might accelerate, and well, let's just say that we would like the average over the 3 months to be a healthy driver, to be averaging 55 miles an hour. Let's just say that that's what we would like to average over the 3 months. But due to circumstances on the road or maybe some fun that we're having or whatever, there's times where we put the pedal to the metal and we accelerate and we're not going 55, we're going 95. Okay. Or 105.
I think that's a great analogy.
Who do you hang with?
Yeah, you see where I'm going? So see where I'm going with that, Lon? Yeah.
Yeah, actually, I have an all-electric car, and I learned when I first got it. I took one trip, a long trip, and I had 16% left by the time I got there. The second time I went on the trip, I said, "Oh, I got plenty of time," but I forgot I was running the air conditioner and the radio and lights, and they're all drew.
Yeah.
So depending on what you eat during the interim, it'll affect the overall outcome at the end, how many miles you can travel. So that's a good analogy.
Yeah, it is. It is. Yeah. So, yeah, that's a great, especially with the electric car. So yeah, if you're driving, and a healthy range would be at the end of your trip, if you could show on your dashboard or whatever that it showed you averaged 55 miles an hour, that would be good. And you could look back and you say, well, gee, I know on that Saturday afternoon, I was cranking it up to 95 as I was going through Nevada, okay, or whatever, and I was really speeding along. But there was probably some other times where you eased off and maybe it was down around 35 or 40. So over the 3 months, you averaged a healthy 55. But if in fact your goal is to average a healthy 55 and you're just getting on it too many times out there over the 3 months and you're doing a lot of 90 mile an hour, a lot of 100 mile an hour, you're going 120 miles an hour, you're almost never down in the 70s and the 60s and 50s. You're just always flooring it. Whee, sounds fun. Whee, okay. But you get to the end of your 3 months and you look at your report, and instead of what you would hope it would say is you're averaging 55, it says you're averaging 85.
Yeah.
Oh, that is an A1C number.
Yeah.
You want it to be in that 5.7 or below, ideally. And Lon, you said that you started off, you were at 6 point, where were you at?
Well, back in December, I was 7.9.
7.9, okay.
So I'll tell my story on Monday night totally, but we'll do it here too. But it went down only on 5 weeks of this program, went down to 6.5. And so my doctor wanted to see how over a 90-day, how this program was working. So I did that just last week, and it went down another down to 6.4. So
yeah.
And so the trending is going the right way, and I ideally need to get below 6 to be free of diabetes. Let me address a question to you, Eric, since we're on this topic. Is diabetes strictly related to diet, or is there a metabolic genetic dimension that causes you to have diabetes? And that you're just managing it, not really, can you really cure diabetes with the Healthpointe program?
Okay, some great stuff there. And by the way, Laurel, I see a hand raised there, Laurel, so I'm going to circle to you in just a second here. Okay, huge caveat. Okay, I'm not anything I'm saying, not diagnosing or prescribing. And also, I'm not an endocrinologist. Okay, so that said, to your last question there, Lon, can diabetes, type 2 diabetes, be reversed? You don't have to listen to me. You can hear physician after physician, doctor after doctor out there that says, yes, you can reverse, type 2 diabetes. You can, and it happens all the time when people, take steps to address it. To your more, it's kind of a murkier territory of, can you always do it with with diet? Is there a genetic component and so forth like that? There's other factors that can drive diabetes. Diet is certainly one of the leading ones, and certainly in America and actually worldwide. I mean, our rates of diabetes has correlated with the rate of increase of processed food, fast food restaurants, sugary sodas, and so forth. And we all can look at the data on that. So there's obviously that's a huge driver, but there can be other drivers to blood sugar as well. Medications can affect this area. Sleep can have some effect on it. In the terms of the genetics, there can be a genetic component. Interesting, some of the research suggests, and it's really fascinating to look into some of this, is not just things with diabetes, but many things that are labeled or attributed to a genetic component are, and I'm not saying this in an insensitive way, I'm just saying it in terms of the research, is that the thing that is being genetically transferred from one generation to the next is not so much the genes, but the behavior.
Mhm.
Yeah.
Okay. So if you have type 2 diabetic grandparents, and then your parents were type 2 diabetic, and then you're type 2 diabetic, can there be a genetic component? Yes. But what the research also shows is that if you look at the grandparents and they, from a dietary standpoint, were eating in a way and they were overweight or obese or lethargic, look inside their cupboards and pantries and refrigerators and see what that generation was doing. And maybe because their kids grew up with that behavior, their pantries and refrigerators and dietary choices were the same. And then when the grandchildren started, their lives, they filled their pantries with, and now in more modern times with even more processed food. And so can there be a genetic component? Yes, but there can be a multi-generational behavior pattern.
You're talking my story. I was from the South, and exactly what you described, meat and potatoes, a lot of spices, and the ingredients, the sugar, a lot of sugar, iced tea, the sweet tea, a lot of those things. But I think I know what I did. So it's genetic. I got to live with it. Pop a pill, just live with it. You're going to die with it eventually. You kind of acquiesce to that genetic excuse. And Healthpointe helped me to realize I can manage that. I can change my behavior. I can change my attitude. I can change my mindset, and I can reverse this diabetes. So thank you, Eric.
Yeah, that's great, Lon.
Eric,
Yeah.
can I,
Yes.
let me make a comment here. I think the genetic more is the type 1. I have a friend of mine who's a type 1 diabetic. He has to wear a monitor constantly that really sends insulin into his system because type 1 is pretty hard to control unless it's done with all the equipment he's got to wear. Whereas type 2, just a general statement, a lot of times can be handled through your nutrition and your style of eating and all that.
Yeah.
That's what I'm understanding from this friend of mine.
That's a good distinction. And maybe comment on juvenile onset of diabetes. There's a factor that they call it juvenile diabetes.
Yes. And I'm going to circle back to that because these are great points, the distinctions that Hank's making and that you're bringing up, Lon, as well. But first, I'm going to go over to Laurel. And I know you've got a question or comment.
Well, yeah, it was from way back, but I was curious. Just a simple question. One was, if I'm looking at my blood test, what am I looking for? They always use weird initials and stuff. They don't always just call it what it is. There's some initials in there. You have to figure out, oh, what does that stand for? So while I
It's a
was
great.
walking, I was looking it up, and it could be fasting blood sugar, FBS. It could be fasting blood glucose, which would be FBG. It said it might just say glucose. So my doctor always has me do a fasting one. So I don't know the number when I look up blood test as glucose. Is that, is there a difference? I mean, is
It's
that
a
the
great
one?
question. I love this because we often talk about, practical and tactical. So what Laurel is bringing out is, okay, all this is great, but I want to look on my lab and let's get practical and tactical. What do I look for? No, it should say insulin. Not
Insulin,
fasting
okay.
glucose. Yeah.
Not
So
glucose.
right. Yep. Because it's
All right.
it's insulin, which
And
is
I
a
don't ever
hormone.
remember seeing anything about insulin on any of my blood tests. So I'm going to go back and look at them.
Yeah, and that goes to the point of my docket item where many labs, despite this being such a powerful leading indicator, do not contain it. And be prepared, if you ask your physician for it, you may get some pushback on that. Just say, say whatever you want to say, but I would just say, yeah, whatever. Can you include it? Yes or no? And just advocate for yourself to get that.
Let me add another comment in here that just came up from what they were talking about here. I remember years ago, which really changed my trajectory of way I was thinking about eating, because I had a family that, loved to eat. Anyway, and it was a doctor that I was seeing, and he said to me, genetics, and in some cases, genetics is genetics, with big things like regular diabetes. But he said, basically, all this other stuff that people say genetics, he goes, remember this, genetics loads the gun, but lifestyle pulls the trigger. I got all these gun analogies. I'm not an NRA person, but, anyway, and I always thought about that. Yeah, you got the genetics, but what you do with it, the behavior that, like you talked about, the actions you do can trigger things to activate, not activate, that kind of thing. That's all. I'll lower my hand now.
And that's great. And Deb, I'll get to you in just a second. But that phrase that you use is a very well used phrase in for clinicians and physicians and educators, that genetics loads the gun, but behavior and lifestyle pulls the trigger. And I know we've done segments on here, more deeply into genetics, and we can talk about even things beyond things like diabetes, where you may have a genetic, what's called a genetic SNP or variant, and through behavior and choices and lifestyle, it doesn't necessarily mean that gene will express. That's the field of what's called epigenetics. The things that you are outside the gene that affects the gene and the expression of that gene. So great phrase there that you brought up, Laurel, and really good insight on that genetic component. Debbie, I think.
Hi.
Debbie.
Yes.
Hi.
I pulled out my blood work from before both my knee surgeries. And so I had a question for you. I had to pay extra for the A1C test. He told me that in advance because I explained to him both of my grandparents, my grandmothers were diabetic, and my mother ended up being diabetic at 70. And so we had the A1C test that came out normal, and it said consistent with the absence of diabetes, but my glucose number was a little high. So there's an inconsistency there. I'm thankful it was 10 or more points lower than my first surgery. So I've been on this program and it dropped. But where do I now start looking? It's because the glucose is a little high. Is that a concern?
Oh, I did.
So on the first question, as far as where do you go to look, is that a digital platform or paper platform you're looking at right now?
I don't understand your question. Paper.
Like, are you looking at your lab report on a computer?
I'm looking at my lab report, and it came out my A1C was 5.6.
Yeah, yep, I got that. In terms of you're asking how to find insulin, if it's in there, is if you're looking on a digital version, there should be a search bar, an
Oh,
hour,
I only have a paper copy.
oh, okay. Well, in paper copy, you're just going to have to look through there and see if there's something that says insulin or fasting insulin.
No, it
And
just
if it,
says glucose.
okay, so that is again why I included it in my docket item because it is interesting, and I'll just kind of just for emphasis, I will reread it here. It says, interestingly, fasting insulin is frequently not included in routine annual blood work. Current national screening guidelines emphasize glucose-based testing, which is what you're talking about, A1C and glucose, because those measurements have long-established diagnostic standards. Fasting insulin is measured accurately by laboratories, but there is less consensus regarding how it should be used as a routine screening tool. As a result, many clinicians with a particular interest in metabolic health choose to use it more extensively than current national recommendations. That's a long way of saying that if your physician is particularly, like a functional medicine person or more in tune with that, they're probably going to include the fasting insulin. But if it's not that type of doctor, you might not find it. So Laurel, it might not be in yours. Debbie, it might not be in yours. Emily and I, for a number of years, have gotten our blood draws through a platform offered by Dr. Mark Hyman. Many of you might know of Dr. Mark Hyman. But that platform is called Function Health. And in the Function Health blood draw, fasting insulin, I think there's like 110 different markers that we get with that program, but certainly fasting insulin is in there. But that's Function Health. And by the way, my fasting insulin for over the last 3 tests has been between 2.1 and 2.5. Okay, so again, you want that number to be, like the normal ranges can, from a standard doctor, they might say even if you're up at 20 or 25, or if you're under 20, they might say that that's normal. Most more specialized clinicians will say, no, if you're above 12, that's, significant insulin resistance. And they want you, ideally below 5. Okay. And mine has been 2.1 and 2.5. So
that's the fasting insulin?
That's the fasting insulin. Yep. And here's so a couple of things here. Just first, a quick comment on something that Hank and Laurel were saying, and then I want to circle back to. I'm just jotting a note for myself so I don't forget. So Hank had brought up, his friend that is type 1 diabetic. And we've talked on a previous episode here about the distinction between type 1 and type 2. Type 1, it shouldn't even be called diabetes, in my opinion. I think that's what I covered in that episode, is I wish they called type 2 diabetes just diabetes or type 2 diabetes, and then called type 1, call it something else, because it is a totally different cause. Your friend that has type 1 diabetes, Hank, it probably happened when he was younger, not always, but that's that juvenile component. It is an autoimmune disease where that means your immune system, for a variety of reasons, but it basically attacked and destroyed the pancreas. So the pancreas is what produces insulin. So if your immune system attacks that organ and destroys it, your body is no longer able to produce insulin. So that's why your friend, Hank, and then years ago, people would die from that, right? Because there was no If you can't have insulin, you're going to die. And so, but now through insulin pumps and monitors that they can wear and so forth, they can basically have almost like a pancreas attached to them that takes that role. So I wanted to be, yeah. Is that?
You're right on that, Eric, because he said it happened to him when he was 14 years of age.
Yes. Yep. Exactly. So that contrasts with type 2 diabetes, which up until recent history, I say probably within the last 2 years, the name kind of shifted because it used to be called, or we would often hear it referred to as adult onset diabetes, right? They would call type 2 diabetes adult onset. You didn't see it in kids, 30, 50, 100 years ago. But now, because many kids are obese, they are getting type 2 diabetes, which used to be called adult onset diabetes, because you would see it usually in older men and women, particularly associated with getting heavier and obese. They would get adult onset diabetes. Well, now, if kids are getting obese at whatever age, 5 years old, 10 years old, they can get type 2 diabetes as a child.
I guess Adrienne doesn't have that.
And we've got a hot mic there with somebody. But yeah, so kind of the one of the key takeaways. Well, first I wanted to just bring up, maybe just for my own fun, that the first time I heard of this was actually one of the first time I listened to material on this subject at all. And many of us are familiar with Dr. Casey Means. She's just an incredible individual that is very, very steeped in this space. And she brought up this topic of insulin resistance as it relates to later development of diabetes. And she was citing things where people could have insulin resistance for up to, some studies showed as long as 13 years before it started manifesting in the symptoms of diabetes. Why is that? Because the pancreas is compensating and working harder and harder and harder to produce more and more insulin to keep those numbers regulated. But so that can go on for many years, but make no mistake, that is not a healthy state for the body. So the body is very unhealthy, but the doctor report might say you're healthy as it relates to your blood sugar. And that's kind of one of the, the key takeaways. I mean, all this is very interesting in its own right, in the science of it, but where does this come down to kind of the practical and tactical? It's if you have, and if you've had somebody say this, or if you've experienced it, comment on it, where somebody says that is carrying a lot of excess weight, they are almost giddy about how they are eating sugary foods, their comment to you is, but my lab report says I'm fine. My lab report says that my glucose is in range. My lab report says that my A1C, and it's kind of perplexing. You're like, man, I mean, with all this excess weight that you're carrying and the way that you're eating, congratulations, it's amazing, but I don't see how. Well, now you know how. Now, if they go and that same person that is obese and eating in that manner in their next blood draw, yes, pays attention to their A1C and glucose, but also gets a fasting insulin number, you could make a bet that their fasting insulin number is going to be way high out of range. So it's just a matter, because the reason their glucose and their A1C numbers are in range is because their pancreas is secreting so much insulin to compensate. So if they get that number, they may be saying something different and saying, uh-oh, this is not good. This is not good. So that's kind of, as coaches, as people in the marketplace, what could be a key takeaway here? Okay, moving on to David Dessau.
I just wanted to share from what I heard everybody having to say today. I know that the question that I ask myself and how I conduct my behavior is, how is my example going to affect my family and my family legacy from generation to generation? And what I heard you say today on the non-medical side was that as we change our habits and as we follow the Healthpointe program, not only do we get healthier, but we're setting a new standard for our family and those around us. And that we, through Healthpointe, we have the opportunity. We often talk about trying to stop the generational effects of poverty, but we're now talking about is trying to stop the generational effects of poor eating habits so that we can have healthy bodies where we have maximum energy and have a long, healthy span. That's what I heard today.
That's it's a great takeaway there, David. Thank you for that. And yes, that is what we're doing here, right? And I would say, kind of along what David is saying is, and that's why I want to make a distinction, in the comment I just made about that person, that friend, that family member that says, but my glucose is fine, my A1C is fine. Now you've got another piece of information where you might be able to help that person. So probably people in this, attending this walk and talk, that are doing the Healthpointe, lifestyle of eating and activity and supplementation and movement, you're doing the things that would reduce your fasting insulin. You're doing the things that would keep your fasting insulin number in a good range, which results in a good glucose number and a good A1C number. So this kind of isn't meant for us in terms of, it doesn't apply to us per se. We're doing those things already. This is more for the people that are out there that are unknowingly high on their number. It's just not yet reflecting in their glucose and their A1C. Just like you could keep a number in range with a drug, right? Somebody could take some sort of a drug and keep a number down within range. Well, insulin is effectively, acting in that same way. Yeah. Great stuff. Thank you again, David, on that. Any other comments, questions? We're basically wrapped up. I feel we got, quite technical here, which is all, sometimes a little scary to get into too much technical, but that's the direction it took. Hopefully, everybody learned something. Hopefully it is tactical and practical. Maybe it's something that, like a lot of things, if you're hearing it for the first time, you might not, fully understand it, but with maybe repeated exposure to the topic or doing your own looking into things, you'll begin to understand it a little bit more. I wish it was part of every standard panel. Yes, Carol, you had a physical hand raise, or no? You're muted. Okay, well, Carol, I'll wait for you there. You got all kinds of things going. Your camera is turning off and on, but I get it. Sometimes it's hard on the phone. Okay. So, but please do chime in, Carol, on anything that you're thinking of right now as I kind of chat a bit on this. And again, you can look, as some of you already have, Laurel, Debbie, look at your own report, see if it's in there. If it isn't, the steps that you could take for your next one. But again, the people in this group, your numbers are probably either good or they're heading in the right direction. That's like what Lon was talking about with his A1C. So if he had been getting fasting insulin numbers and maybe they were high and out of range, just like his A1C is high and out of range, it's heading in the right direction. We're doing the things that affect the numbers, because the point with any lab or anything is not just to get a report and stare at it and say, well, it is what it is. It's what can we do about this, if anything? And in this case, there are things that you can do on that. So, all right. Well, there you have it. On the one docket item that we tossed around and chewed up and threw this way and that way and got a lot of great commentary and reflections on this. That said, any other comments or questions before we kind of wrap up here for this Saturday?
Yes, Eric.
Yes.
Since Carol, for some reason, we can't get Carol on, Monday night is going to be a lean team. Monday night, back to the regular routine of lean team at 8 o'clock, okay? Eastern time.
Yes. Thank you for that. And Carol did mention that in the preamble, but yeah, that's a great point to bring up here. So everyone, Monday night, 8 p.m. Eastern Standard Time, just 30 minutes, 8 to 8:30. And Carol, you had mentioned, and Lon, you had reflected in some of your comment, you're going to reflect more on your story. And I think Jerry and Sharon, Carol, I see you're unmuted. You go for it. Go ahead and give that announcement.
I got no. Well, okay, yeah, that's right, because I did it beforehand. Yes, Lon and Altali Holly will be doing their story. I'm not sure if it's one or the other or both of them. And Jerry and Sharon Webb are going to be interviewing them, and based on some of the things that Lon talked about today, I think it's going to be very, very enlightening and quite a different take than the extreme weight loss. It's going to be in a very different manner, is what I'm understanding. So we're really looking forward to that. That will be on our Monday Night Lean team, and that invitation will go out. So invite your people that want to improve their blood numbers, because this is a perfect example of what Healthpointe does. I did want to make one comment, and finally I got back on. So and talking about the driving of the car, it makes me think of when you get behind the wheel of your beautiful car and you gun it and then you hit the brakes hard, and you're just a very aggressive driver and you're constantly pushing the gas and then you're pushing the brake because you're in a hurry. That's wear and tear on the car, much similar to what we do when we have our donut and then or maybe we do everything really good during the week and then we just absolutely blow it on the weekend. And then, okay, Monday comes around, we got a protein day, we can take care of all of this and make it all good again. And we do our protein day and we do a few days of Healthpointe, that's good. But then we gun it again on the weekend. Eric, help me with this, but is that not a lot of wear and tear on the body? Much similar to what you were talking about today?
Yeah, it's not an ideal way to go, just as you're mentioning about with a car analogy and so forth. And there's been more than one time that I've commented, and I say this just as a flippant comment, don't take it literally, but I've said to some people, I almost wish there wasn't a protein only Monday, if people are using it as a tool to go crazy on the weekend. Okay. Protein only Mondays are wonderful. And if you do find yourself eating kind of poorly due to whatever circumstances over the weekend, it's a great corrective measure for that. But that's different than saying, because I know I'm going to do a protein only Monday, I'm going to eat horribly, Saturday and Sunday. That's not a good thing. You don't want to be throwing your body into a herky-jerky thing like that. So yeah, I would agree, Carol.
Okay.
Yeah. All right. Well, guys, you heard it. This again, kind of on the same cloud with Lon. I didn't know that Lon was doing the being on the program. Maybe Lon and Eltalie or whoever it's going to be, and we're going to be talking about maybe some of these lab numbers, which is not often the case with the stories. But here we are on the same page again. So it's been fun. It's great to be back after our short break. We'll plan on next Saturday, same time, same place. And until then, bye-bye.
Thank you, Eric. Bye-bye.
Bye.
Thanks,
Thanks,
Eric.
Eric.
Hi, everybody. Have a great weekend.